Welcome everybody to BlockHeads for February of 2026. Super happy to have you here. We'll be discussing a new approach to cervical radiculopathies and upper back pain with Matthew Lipton here, related to the two-in-one ultrasound-guided hydrodissection of these areas. So I'm going to let him kind of take things over and love to hear what you have to say.
All right, thanks. Hey guys, I'm Matt Lipton. I'm one of the ultrasound faculty at Vanderbilt in Nashville, Tennessee. I'm also the fellowship director, and I'm going to today talk about a new hydrodissection that I find very interesting, and I'm hoping to present it to you guys and get your guys' take on it because I think it has the opportunity to relieve a lot of pain in the emergency department. So, without further ado, um, drop this down. So we see a lot of lower back pain, but I would say that at least at the VA where I work, we also see a fair amount of upper back pain, especially kind of this medial scapular pain. And it is a very common problem, not only just isolated pain in that location, but it's also frequently a component of cervical radiculopathies. And so this is actually a note that I saw yesterday when I was working at the VA. This was not my patient, but someone left this at the doctor's desk. And I thought I'd just add it. I have a cervical radiculopathy. I require immediate consult to a doctor that can provide either a nerve block or radiofrequency ablation, or I kill myself. And that's just to show how painful these things can be. I know you guys know this, but some people are in dire straits. And so we're going to be talking a little bit. It's almost like kind of like a journal club here at the first part, because this article, it was called the Ultrasound-Guided Two-in-One Hydrodissection of the Spinal Accessory Nerve and Dorsal Scapular Nerve. It is an absolute mouthful, not a very nice procedure name, but it's very descriptive of what we're doing. And this was first presented about 2 years ago in the Journal of Emergency Medicine Reports, which unfortunately is not a PubMed indexed journal. And so it can be a little hard to find. But they did a case series of two patients with a refractory upper back pain where they did this block, which I will describe in a second, or I should say hydrodissection, of the spinal accessory nerve and dorsal scapular nerve, and had great success. So before we talk about the actual how to do it, let me just remind you guys about hydrodissection. So in hydrodissection, you're usually injecting dextrose containing fluid to separate a nerve from its surrounding tissues. And it's thought that the expansion of the fluid around the nerve will help relieve the compression from the adjacent structures. And there's also some thoughts that it creates some down regulation of some painful receptors. And I love this term that corrects perineural glycopenia and then improves nerve mobility. So these are the different theories as to why a hydrodissection with dextrose containing solution may work. So as to the actual nerve, let's talk about it here because we're going to hydrodissect two nerves out. So the first one is going to be the dorsal scapular nerve. So if you remember from your brachial plexus anatomy here, if you're viewing this from the front, here's your dorsal scapular nerve. It is a branch of the brachial plexus coming from C5, and it is going to go posterior after the very quickly. And if you look at it, the patient from the back, it quickly comes down and goes to your medial scapular border here. It actually innervates your rhomboids and is actually found underneath your rhomboids as well. And it's primarily a motor nerve, although it has some sensory fibers. And it has been well described as a cause of scapular pain, entrapment of this nerve as a cause for chronic scapular pain. So um, that is the least controversial nerve. The spinal accessory nerve is even more wild. So this is a cranial nerve 11. So if you actually have little rootlets that come off the spinal cord, go into the skull, and then come back out and go down your sternocleidomastoid and go to your trapezius. Because if you remember from medical school, to test cranial nerve 11, you have people shrug their shoulders since it innervates your trapezius. But this is a cranial nerve. And again, this one is mostly a motor nerve, but there's some recent evidence to suggest that it also contains a small amount of pain fibers in it. But this one is not nearly as commonly described as causing scapular pain as the dorsal scapular nerve. All right, so we got those two nerves. So let's show the anatomy really quick. So going from superficial to deep, you got your trapezius muscle here. If you cut away that muscle, then you got your rhomboid muscles here, which is also cut away a little bit. and then finally your serratus posterior muscle. And so these are the three targets that we're going to look for on ultrasound to identify our fascial planes, because the spinal accessory nerve is going to lie between the trapezius and the rhomboid, while the dorsal scapular nerve is going to lie between the rhomboid and the serratus posterior. So going on to an ultrasound sonoanatomy image, this was a pretty muscular person that I obtained an image on, so it was very nice. But if I have my linear probe on the medial scapular border with the probe marker cranial, again, you're going to see your trapezius on top. You're going to see your rhomboid in the middle, and then your serratus posterior deep to that, and of course your rib. And then your spinal accessory nerve is going to lie in this top fascial plane, and the dorsal scapular nerve will be in this bottom fascial plane. All right. So I explained the where the nerves lie, but let's go back into the journal article and show what they did. So these are taken directly from their case report. 68-year-old patient, diabetes, hypertension, coronary artery disease, left upper thoracic pain radiating to the left arm for 2 days that was intermittent and shooting down the arm. And I'm going to put a pin in that arm component. The patient had, on the physical exam, had some left paravertebral tenderness near the medial scapular border. They did some cardiac workup to make sure it wasn't anything more serious, which was all normal. They gave him a gram of acetaminophen and a lidocaine patch, which didn't do anything. And then they did the block, the 2-in-1 hydrodissection. And how they did it was that they took 20 cc's, which composed of 5 cc's of bupivacaine, 0.5%, and 15 cc's of D5W. So 20 cc's total, and did 10 cc's into each of those fascial planes that I described on the last slide. And in 30 minutes, the patient had 0 to 10 pain, and then they called them at 48 hours, and they still had 0 to 10 pain. I mean, that's like mind-blowingly good. And then the second patient wasn't as good as this, but pretty good still. 47-year-old guy, severe atraumatic right scapular pain for a couple weeks. Again, it was severe. This one also had pain radiating down the right arm associated with numbness and tingling. They were previously diagnosed with a pinched nerve, failed conservative therapy, with lidocaine patches and NSAIDs. On physical exam, this person also had some tenderness of the medial scapular border, but a normal neurovascular exam to the hand. They gave him a shot of Toradol and a lidocaine patch, which didn't help. They also injected this person with the same technique that we described before, and in 15 minutes, their pain was dramatically better. They didn't call this patient to follow them up. And so my big question here was both of these patients, although they primarily had medial scapular pain, they had pain radiating down to their arm. And initially, I thought this was just going to be a block for this pain here, which I would say is not terribly common in the emergency department. This medial scapular pain, maybe up to the neck. This is the area where the dorsal scapular nerve really innervates. But it really sounded like they had cervical radiculopathies without saying it. I actually emailed the authors a while back, and they never got back to me if these people had cervical radiculopathies clinically, but it sounds like it. And so then I investigated, why would you get scapular pain from cervical radiculopathy? And there's not the best information about this on a deep dive, but in short, if you look at all these cervical radiculopathy syndromes, you'll notice that each one of them from C5 to C8 has medial scapular pain, as seen here, with varying amounts of arm and shoulder involvement. So, it is a well-described phenomenon. And in fact, this bigger study, or at least a study that looked at where the most pain is from cervical radiculopathies, they found that behind the neck and arm, the scapula was number 3 most common area of pain at 72% people with cervical radiculopathies had scapular pain. So I suspect that most of these people in the study actually had cervical radiculopathies without them saying it. So this gives me now a target for a very common diagnosis of cervical radiculopathy that we see in the emergency department. Oh, one note, this slide might hurt some people's brains. Some people might say, you know what, if it works, it works. I don't really care how it works, but it just blows my mind how if we're hydrodissecting this nerve here, the dorsal scapular nerve C5, and you have a cervical radiculopathy a lot lower, like say a C7, which is usually this is where the herniated disc pinches on right about here. how doing an injection at C5 or a scapular dorsal scapular nerve hydrodissection could help at all a C7 problem. And I don't know this. I mean, it's not very clear. This is more just like proposing it out there. But C7 also has some little dorsal rami branches that come out to the skin back here. So that's probably what's causing the pain in a cervical radiculopathy, these little dorsal rami back here. But again, if you're hydrodissecting up here, how does it help down here? I have no clue. If anyone has any thoughts, so this would be great on the discussion. Going back to the article, here's the picture that they show. So again, the linear probe, medial scapular border, crania pointing cranially. They found the trapezius, the rhomboid, and the serratus posterior. And then again, they injected 10 cc's in both this plane here and the deeper plane as well. After, they obviously did a skin wheel as well. And here's a video of myself doing it. I've done this about 10 times now because I work at the VA and we see a ton of cervical radiculopathies, and a lot of them have medial scapular pain. And so here's this was another muscular gentleman, but I'm first at this interface between the rhomboids and the serratus posterior, and I'm injecting here, and I'm getting a nice spread of local anesthetic. And then I will inject it a little bit more to make 10 cc's total at this fascial plane. I'm going to withdraw my needle to go to the more superficial plane up here. And then I'm going to inject another 10 cc's on this fascial plane up here. And honestly, like I said, I've done this probably about 10 times now. I've had very good success with this. And most of these people had cervical radiculopathies, like clinically. I did an MRI, essentially any of these people. Clinically, cervical radiculopathies with medial scapular pain, I injected them and they had dramatic improvement of their pain. I didn't follow them up. I didn't make this into a study, but I don't understand why this works. But this would be a good discussion to have. Because most people with cervical radiculopathies don't involve C5, and they definitely don't involve cranial nerves either, which is the spinal accessory nerve. And then I also wondered, like, why do you need to hydrodissect the spinal accessory nerve since that's not involved? And it's probably mostly from the dorsal scapular nerve, if I had to guess. And do you even need bupivacaine, or is just D5W enough? Like, why did they add that? And finally, I think this question often arises, can you add steroids to the dextrose to see if that could prolong the effect? I'll just bring up one patient that I had that had a cervical radiculopathy into their hand and actually had true motor weakness, not pain limited weakness, like true motor weakness. I told him he needs an MRI. He didn't want it. He's a typical vet. He's like, hell no, PTSD, scared of MRIs. So I offered him this dorsal scapular nerve hydrodissection. He accepted. Within 30 minutes, he had dramatic improvement of his pain, and his weakness of his hand grip was gone, or nearly gone. And again, it was not a pain limited thing. I don't understand how that would work if it was psychogenic or not, but it was pretty dramatic. So anyways, I'd like to open this up to any comments, questions, thoughts.
Hey Matt,
Yeah.
this is awesome. Thank you. What do you think about I guess the hypothesis that this is kind of like an ESP by proxy? Do you think that maybe with the volume that it's just kind of spreading into that paravertebral space? I mean, that's it using a fairly large volume of local in those tissue planes. I'm sure there's got to be some sort of spread there.
Yeah, I guess I haven't thought of that. We're not, ESPs are pretty close to that paravertebral space. Whereas this, right next to the scapula. So, I mean, it's a couple more centimeters laterally. Yeah, I don't know. I haven't thought of that. If that would fix it, but because I know they have described cervical ESPs, and not that I've ever done that, but that's a great thought. I'd have to look into that more. Has anyone else tried this or had a patient that would benefit from this?
I haven't done these. I've had a lot of patients who I've done like T2 ESPs on, and it also works really well for this type of pain.
Oh, okay. So you're doing T2 ESPs for cervical radiculopathies.
It spreads up to about C4 if you use about 25 to 25 mLs of local. If you
Gotcha. And so you are using just a local anesthetic instead of dextrose.
steroids sometimes too. Yeah.
Steroids. Okay. Interesting. I haven't used that. But yeah, we just see so many patients in the VA with cervical radiculopathies that have chronic pain and can't, get into the appropriate places, whatever. Even if you're going to try and set them up with an epidural steroid injection, it's nearly impossible to do it within a month.
No, it's amazing. I think it's really cool. I mean, it's definitely low. It looks like it's a lot like I think lower risk, especially if you don't like getting near that kind of the intertransverse process, like space, that space over there approaching kind of the actual spine. I think it's awesome.
Yeah, yeah, and I mean, it's great since generally with 5 cc's of bupivacaine, I don't necessarily. I know there's a little controversy here, but generally, if I'm using 5 cc's of bupivacaine, I don't have people on the cardiac monitor. That might be a little controversial, but I think people always say you got to put them on the monitor for a block, but geez, it would cripple our emergency department if we tried to do every little injection on the cardiac monitor. So these people are usually in fast track. We observe them for a bit and send them home.
It's awesome. I'm gonna try it.
Yeah.
Yeah, we typically have a cutoff of about 10 cc's or nearby any kind of a vascular structure for cardiac monitors too. So I think you're still in the clear with that. Great idea, by the way. And I'm kind of wondering whether the innervation actually of the posterior upper back and neck does have a little bit of room to kind of tease out a little bit. Because the other thing that I was thinking of, and I think Rich and I were side texting too, is the low paraspinal cervical injections too, which kind of marinate the similar territory, but the innervation of the dorsal spine, the cervical nerves actually kind of dump into the trigeminal cervical complex, which is involved in migraine management. So I'm wondering whether there's a little bit of a feedback loop there too. But
Interesting. Are you
interesting.
talking?
Huh?
Oh, I sorry. Are you talking about like just a kind of landmark based C
Yeah.
para? Okay, okay, of like 1.5 cc's bupivacaine each side.
Correct, correct. And that's typically done at about the level of C7 in itself. But,
Mm-hmm.
I love me a good serratus action, even if it's posterior.
Yeah, everyone loves the serratus posterior now. Yeah, it's pretty interesting. It just physiologically doesn't make any sense to me how this works,
No.
but it's kind of like if it does, really, who cares?
Right? It would be interesting to generate some more data on that.
hmm I mean, this is coming from, I've tried to look up more studies. No one's really published on this besides these two case reports or case series, I'm going to say, with air quotes. But yeah, this is not even nearly as published as other transgluteal sciatic nerve hydrodissections or anything else.
Mhm. This actually scared me a lot when you first presented it because I thought that you were going to be hitting the dorsal scapular nerve and the middle scaling muscle. And
Mm.
and I was just like, oh my God, that's like the thing that I never want to do. So, but
You
this
mean
is this is really neat. It's
you mean
awesome.
doing actually like a brachial plexus block way up here?
No, like if you're like when you do the inner scaling plexus block, the dorsal scapular nerve runs right through the medial scaling muscle.
hmm
So I thought you're like you were somehow hitting it there,
Oh
but
yeah, thankfully not. This is pretty muscular area with a lot of room for air here.
cool.
Any other thoughts, questions, comments? Drop my slides here.
Yeah, I don't know if anyone else talked about, Gabe and Dazia doing the sciatica hydrodissection, but the mechanics that they describe with, dextrose and trying to downregulate some of those like ischemic or um, you know, compressive hypoglycemia or whatever their mechanism is. It's the same people trying to prove the same concept and not using any local to try
hmm
and figure out these various places where this might work. So it's interesting that this was the next location for them compared to the compression of the sciatic nerve. So I wonder where they have their target to be next.
Yeah, I know. Just go through each entrapment neuropathy and end up injecting it and reporting it.
Yeah. It's,
I'm probably going to try this next time with no bupivacaine, just try dextrose only and see if I'm going to try and be a little more intentional to call my patients at the 42 or 72 hour mark, 48 or 72 hour mark, just to see their response. I haven't been very good at that, but I'd love to know if this is actually an effect that's lasting longer than the bupivacaine or something from the emergency department perspective.
right. Now, it sounds like those two vets that you had your case series on haven't come back yet either. So it sounds like you're probably onto something.
Yeah, yeah. I will say some do come back. I don't know if you guys have this experience where you do. I did a transgluteal static nerve hydrodissection the other day, a couple weeks ago, and they came back asking for a repeat one, 2 weeks later, and
Mm,
all the non ultrasound people were like,
no.
no.
Yeah, we get a name in our departments, don't we?
Yeah, yeah. They curse me. I usually get a text message when someone bounces back, and it's usually never a bad bounce back. Usually they're requesting another, block or
Mhm.
hydrodissection. But
Yeah,
You're their PMD.
yeah.
yeah, exactly.
Hmm. So this is really interesting, and it sounds pretty easy. So I'm willing to give it a go. Did they have any specifics as to which rib they're targeting for this, whether it's like second, third, or whatever?
Mm-mm. They just said the medial scapular border. I think it's an upper superior medial scapular border.
And
Um,
whichever rib happens to be there.
yeah,
Hmm.
yeah,
All right. Would like to have a little bit more specifics on that if they were available.
yeah. I've
Well, they
sometimes tried,
compromise.
rub the area, trying to allow for a little bit better spread of the hydrodissection, give them a little massage therapy.
Hmm.
Hmm. Exactly.
Awesome. All right. Well, I'm gonna give it another 30 seconds for anyone's last comments, questions, thoughts, musings. All right, fantastic. I think I'm gonna give this a go on my next one and
Sweet.
see if I can report back and see what we find. Really appreciate
Cool.
your time. Hope you have a great
Yeah.
rest of your day. To all my other
All right.
blockheads out there, keep blocking. We'll see you next time.
Bye,
Take care,
guys.
guys.